So, Dr. Rob Whitfield is a board certified plastic surgeon and national leader in breast implant illness, explant surgery, and regenerative fat transfer. He has performed thousands of implant removals and over 1,000 fat transfer procedures, and published the largest PCR-tested capsule study showing bacterial contamination in nearly 29% of cases. Disclaimer: any of the guidance offered by the podcast host, myself, or the podcast guests is our own guidance. We are not liable for any of the actions the podcast listener decides to do. Welcome to the show today, Dr. Rob. Glad to have you on.
Hey, thank you for having me. I really appreciate it. Always good to talk to somebody in the UK.
No, I appreciate that. It's always good to meet people in all areas of life, and it's really I really appreciate like this topic. It's definitely new on this podcast, and what you're doing to raise awareness. I'd love to start, Dr. Rob. What drove you to plastic surgery in the first place as a surgeon, and then what specifically about breast implant illness interested you?
Yeah, sure. For the listeners, I started out in a traditional surgery route because I wanted to do heart surgery. And then throughout the course of my training, a lot of things changed. The advent of stents, you may know what a stent is, the stent open an artery. That all started while I was in training, and it changed the trajectory of cardiac surgery. Obviously, there was a lot less surgery and a lot more stenting, and that was done by the cardiologist. And from an adult standpoint, you would have a lot less heart surgery cases to do. And then from the pediatric standpoint, there's never as many cases for pediatric heart surgeons to do because there aren't that many pediatric heart surgery cases to do in general. So you'd have to do a combination of those. And then as I was going through training, we do a year in the laboratory. And I really got involved in microsurgery in the laboratory. And that really turned my direction towards basically doing reconstructive microsurgery, which is the purview of plastic surgery. So I did general surgery for 6 years, spent a year in the lab, also spent time in the UK at Cambridge during that time. And then I did 2 years of plastic surgery and then the other year of just microsurgery. So 9 years after I got done with medical school training, and then practiced for really 7 years at an academic surgery program, taught plastic surgery, taught microsurgery, and then transitioned to a group practice in Austin, Texas, where I am now. And similarly did the same procedures, head and neck reconstruction, breast cancer reconstruction, sarcoma reconstruction. And I had a breast cancer patient come to me who had retired in Austin and wanted to have their breast implant reconstruction removed and go flat. So you can have different types of reconstruction, or you can have no reconstruction. She had one with an implant and she just wanted to have it removed. And, for her own personal reasons, it didn't serve her anymore, and have a flat closure done. And so I did that for her. And then, so for everybody listening, I have done things as I was trained to, when I was trained to take out any material, you would always send that material off to the pathologist. You would test it for cancer, and you would also make sure there was no infection that could potentially harm the patient from where you were removing everything. So when her testing came back, she had no evidence of recurrent breast cancer. First and foremost, you want to make sure there's no evidence of recurrence or a new cancer. And then the other is you want to make sure there's no infection in that space. And she, like I said, had no cancer, but she had an E. coli infection based on the criteria of the laboratory that was used at the hospital. And so that was really quite shocking to me because I had done all of the preoperative assessment, examination, review of studies, blood work, all the information, and none of that led us to believe there was a problem. But having said that, she had a symptom that actually a lot of people who've had cancer treatments have, which is fatigue. She did have that. And when I explained to her the findings, and I said, the therapy would be a particular antibiotic that would help treat that for her. And so we did that for her, and her fatigue all resolved. So she had walked around with a unknown implant-based infection by the criteria used in hospitals to establish an infection for a period of time we don't know. And she couldn't remember when she didn't have fatigue, so it wasn't like an event we could track. But for everybody listening, there's 3 ways to get an infection if you have an implant, whether it's a hip implant, knee, breast, dental, cardiac, neurologic. And that is when the implant is given to the surgeon in the operating room. So they're usually double packaged. They open that package and somehow there's a break in technique there. The next opportunity would be the surgeon somehow breaking technique upon placement and contaminating it. So those first two are really, really uncommon in today's environment because of all the steps taken, both with, like I said, packaging, and then the surgeons who place implants would typically, there's all sorts of precautions, including, the orthopods wear spacesuits. Many people are changing gloves multiple times, using no-touch techniques where the implant is not even touched upon placement. So there's all sorts of steps taken to avoid, those first two opportunities. The third and the most common is just basically life. So you go throughout life and you may get a skin infection, you may get a bladder infection, you may get a lung infection. All these things allow bacteria to get in your bloodstream, and then those can attach to an implant because the implant's foreign, it's not your own tissue. So our body's natural surveillance system can't really clear it. And then as they find their way to this device, we'll say, or grow on that device, they develop these communities or biofilms. The original biofilm is like plaque on your teeth. And the thing is, it can cause a signal between the bacteria and your tissue, because the scar tissue that forms around any implant is just basically your body's like a collagen sac that forms around. Whether it's a hip, knee, breast, dental, cardiac, neurologic, it doesn't matter. It's all kind of similar, right? It's basically a collagen sac. That collagen makes this kind of scar formation, but it's not impervious. It doesn't block everything. Think of it more like a screen or something that's knitted and can be stretched apart. So signaling can happen between the bacteria and your tissues. And in the breast tissue specifically, there's something called oleic acid, which is just a fatty acid. And the interaction between the bacteria and the fatty acid causes oxidative stress. So it creates an oxidative reaction. And the more oxidative reactions we have, the more it builds up in our system, and that can create symptoms through an immune system activation response. So we always want to have a good balance between oxidation and reduction. We want to be more in a reduced state. If your cells are working too hard, they create too many oxidative free radicals, and then it's a burden for your body to take care of all that. That can lead to problems with your mitochondria. It can lead to fatigue. In these patients I'm describing, it can lead to more symptoms of chronic inflammation. So that's like a cause and effect. And we published the big paper that shows that 29% have bacterial contamination when we remove the scar tissue and just test the scar tissue by PCR analysis. So there is more, I would say, foundational information now than there ever has been about that interaction. And biofilms are not, like I said, the original biofilm that was described through the use of a microscope is the plaque on your teeth. I mean, it's not that these things aren't understood. It's just their level of our level of understanding about what's happening at the tissue level is not that well understood because it's not easy to measure, right? There's not a blood lab that can be done that can be like, oh, this is the problem. This tells you it's this much inflammation in this person, because everybody's very individual. They have certain genetic characteristics. They have certain exposures over time. You lived in the UK. I visited the UK. I lived in a dorm at Cambridge. I've lived all over this country and got exposed to different things. I'm uniquely sensitive to something common in the air where I live in Austin, which is mold. There's a lot of mold in the air here. So it causes a pretty significant allergy response to me. And that's just an example because we're all very different. And how we handle all of those exposures, everything we put on our skin and in our body creates a reaction that your body has to cope with. And your liver does the bulk of that work. So there can be a lot of stress there. And certainly the information is getting better. We're understanding the science a bit better now. So I feel we're making progress slowly but surely.
Oh, wow. That's an interesting route of how you went from looking at doing heart surgery and then ended up with looking and implants and then doing your work of explants. That makes a lot of sense what you said about actually the body builds up, might get different infections, and then if they find something that wasn't there before, they might latch onto it as well.
Yeah,
that makes a lot of sense. So when women come to you to get surgery, is it a mix between like illness and psychological reasons that they want surgery?
So I think most people arrive at a decision where, the concern is over health and alignment.
Mm.
If they don't feel well, that's certainly a big factor. It may not align with them. It's a decision maybe they made earlier in life that doesn't make any sense now, later in life. So we do a lot of things when we're younger that are probably impulsive and not well thought out because we don't have a lot of life experience when we're younger to reflect on and say, oh, that's probably not a good idea or that's not a great decision. And usually when you're younger, it's hard for people to tell you much. We all kind of face those challenges when we're younger. Now, many people have, these signs and symptoms of chronic inflammation that haven't been able to be sorted out other ways, and they're concerned that this might be a reason. And for everybody listening, I don't tell anybody to get an explant. That's not my role. My role is to really educate people, just as I did, about what I've found and what we've published. And I think science, is getting there once again. There's new papers. One was published out of Denmark last year that showed at the tissue level, there's more of an immune response. And it's creating more and more immune system activation via antibody production and other cell activation. So I think, we're not there yet, like I said, but we're getting, more information with, more availability of, I think, the actual scientists being involved with evaluation of the tissue samples and using molecular techniques to better understand and characterize what's happening at the tissue level, and where we didn't have that in the past. I mean, implants have been around since the 60s. Molecular techniques have not been around since the 60s. So these scientific techniques and, the Genome Project being completed in 2003, all these things really lend itself, for lack of a better word, to us understanding more about what's going on, at the tissue level in patients versus, what we see outside, because that can be very misleading.
So your big drive for you sounds like, as you've touched on, to educate people on actually what's going on, what could be going on in the body, and publish those papers and get that news out there, as well as a surgeon.
Yeah, I mean, most important thing you could do is just provide the information in the most logical, well thought out manner so people can understand it, so they can form their own decisions about what they want done. That's basically what I feel is my role. I'm not trying to tell somebody to do something. I'm not steering somebody one way or the other. I'm just trying to educate patients so they better understand what's happening given the current state of the literature and what we know. And we're happy to be part of that dialogue and discussion. So I feel that's important. You want to really expand that for patients so they better understand what's going on.
And help them come to their own decision, it sounds like.
Absolutely, yeah. I don't need to tell anybody to do anything. That's not my job.
What's, just touching on it again, what's regenerative fat transfer?
Yeah, so fat transfers have been done for over 100 years, and there's been this dialogue around their efficacy. So fat, when you put it in the face, you just need tiny amounts, and you want to put it deeper, not superficial, because it typically heals very well. And then if somebody has a fat transfer for augmentation of the buttock, they need a fairly large amount. It needs to be placed above the muscle, but because of the space occupied by just the buttock in general, it's a big area relative to the rest of the body. You need a lot of volume to make a visual difference. So you can put easily, if you don't put like half a liter in there, 500 cc's per side, you can't really see a visible change in an average person. That seems like a lot, but a half a liter, 500 mLs or cc's. Now, if you're doing the transfer to the chest area, males and females both have breast tissue of varying amounts between the skin and fat layer of the chest and the pectoralis major muscle. So fat belongs in the fatty layer. It doesn't belong in the breast, and it doesn't belong in the muscle. So as long as you're putting it, I like to say, with its fatty friends, it has its best chance to survive. In our country, it's not FDA approved to do anything additional to augment the fat and its ability to heal. You would like to be able to add more what's called stromal vascular fraction, or augment it somehow so it would give it more of a boost in terms of healing. So currently we can't do that. It's not FDA approved. There's only minimal manipulation. So I can take fat out, leave it in a contained system, and then, not do much to it. Like we have a vibratory plate to separate fluid from it. And then We don't do anything else other than a simple sterile saline rinse to it, and then we put it back. It's all in a closed system, basically, so there's no introduction of any foreign bodies or other materials or things like that. And then post-operatively, we have a very aggressive program with things like hyperbaric oxygen, lymphatic massage, obviously proper nutrition support, and red light therapy and NanoV therapy, things that help, including the human regenerator. There's a big company out of London that distributes those. We have one in the United States at my clinic. And so all these things are meant to help with healing. And that's what we have like currently. That's kind of the best situation because of the kind of limitations we have on use of your own stem cells, even though it's your own stem cell fraction we're talking about. It's not FDA approved to do anything with it here.
Nutrition sounds like it might be quite a big role in recovery as well.
Yeah, we work really hard to get a lot of awareness around protein intake and maintenance of body composition and BMI, specifically trying to keep the BMI stable or up it a point or two. And people get worried that I'm telling them to be unhealthy by upping their BMI, but there's putting on lean muscle mass as a way to increase your BMI by improving your lean muscle mass fraction on your body composition analysis. And that will help with maintenance of, and think of like resiliency, right? You want to maintain lean muscle mass. You want to not lose bone density, because those things, as we get older, expose us to things like fractures, especially hip fractures, which are, a consequence of maybe loss of thigh strength or balance issues, both of which can be avoided by walking and lifting weights, doing resistance training, maintaining your lean muscle mass.
Have you had anyone ever come to you from like the fact that they'd had surgery before and they've been let down, or they're a bit skeptical about doing another operation?
Of course, yes. Yeah, I have patients who are concerned about having these removal procedures or fat transfer procedures because there's a lot of dialogue on the platforms or on the internet in general about the viability of these things and how they work. And there's a lot of influencers talking about certain things, and whether it's a fat transfer or another procedure or medication. And once again, a health influencer doesn't have any quote unquote credentials, right? They haven't operated on anybody. They don't know anything about the procedure or the recovery of the patient from the procedure or the preparation of the patient prior to the procedure. So it's a little difficult for me when I get asked, what someone wants to have done, and their friends in Dubai, and their friend in Dubai is telling them XYZ about the procedure, which happened to me recently. And I was like, what does your friend in Dubai do? And, the answer was they read.
Okay.
And I was like, okay, well, that's fair. I mean, I appreciate that. You should be educated and informed. I don't know what they're reading. I mean, I've written a book about the methodology we use to prepare and recover patients called the SHARP method. And I've written a book about breast implants, explant surgery, and breast implant illness. And I've published a bunch of scientific articles and done about 4,000 videos and 160 podcasts. So I don't know in particular what this person is reading about to gather information about the topic that I just mentioned. We've put forth the information about. Once again, like everybody gathers information, like what is the source of the information and how are you drawing a conclusion about the information? So I constantly get asked about fat transfers and why they do work and why they don't work, and why do I think I can do one versus Dr. So-and-so who says, no, that's not possible. It's, literally like not gonna work after a year. Like there's all these things that are said, none of which have any, I don't want to say merit, but they don't land on like a logical conclusion, right? So if fat works in the face and fat works in the butt, why doesn't it work in the chest? Is that because we don't know what we're doing? Are we not handling it properly? Are we not transferring the amount? I try to say things that make sense, right? Right place, right time, right amount. So if you have those criteria and you try to prepare the patients properly, and the patients are, following instructions and doing, what you want, lowering inflammation, you've evaluated their toxicity, they're working on their gut, their hormones are balanced, and they're trying to do all the things in terms of diet you want, also not like overtraining, not doing high intensity interval training or running or cycling or things like that, then those are the patients who have the opportunity and have met the criteria to have this done and will most likely lead themselves to a successful outcome while maintaining a BMI like we talked about and not dropping down. Because if you overtrain, and I use that because a lot of women overtrain, if you create a caloric deficit after something like that, you will definitely affect the result. So you have to maintain balance. And when I talk about BMI, I'm very specific about it and getting things like DEXA scans to better analyze body composition, because that's an objective way to look at it. It helps everybody understand how someone is starting the process, because many people don't understand their body composition, their lean muscle mass, their actual body fat, their bone density. And that's important to understand if you're going to, put yourself into a situation where you're going to have a procedure, or if you're a provider trying to get data to help someone make a decision about a procedure, rather than just saying you can do something and it may have, a outcome that's different, and the numbers are kind of all over the board. And in terms of success rates, I like to think if we get everybody in the proper position, prepared, they do the best on their end to maintain their nutritional status, their BMI, and keep their training so they don't create caloric deficits. Those things, you can have good outcomes. I don't feel like just because you put it in a butt and just because you put it in the face, you can't put it in the chest and not get a good outcome. Obviously, those are very different spaces, but I like the planning that goes into it, and I'm always trying to improve it and optimize it for patients so they can have the best possible outcomes.
Okay, and presenting the information, what you've learned, what you've done, what's going on. It's like you're informing them as you can. I'd love to touch on the SHARP method you mentioned, something you use. Could you tell us a bit more about that?
Yeah, it was really, I had a group of patients that we took care of after explant surgery that just had a tough time recovering. And we didn't understand why. And in 2021, we got a genetics vendor, and we sat and talked about different genetic detoxification pathways. And everybody at this point has kind of heard of something probably called MTHFR. And the UK Biobank has done a ton of work on genetics, and they have a wonderful set of studies and things. This one's very unique to patients who had explant surgery. So we looked at their genetics, and many of them have limitations in their vitamin D metabolism, the methylation pathway, how they metabolize and utilize glutathione, and also things in their antioxidant pathways. So that coupled to problems with estrogen metabolism led to probably a pretty hampered detoxification system. So the more exposures they got over time throughout the environment or the food they ate, or where they lived, the products they applied to their skin, or whatever the series of exposures were, it would reach a limit, and then their body could no longer cope with that. They had exceeded it, and they'd become more and more symptomatic. So think of like signs and symptoms of chronic inflammation. In the neurologic system, you can have things that are as odd as like short-term memory loss in a really young person. You can have ringing in the ears. You can have visual changes. You can have chronic problems with the sinuses requiring surgery, when in fact there's probably not an indication for the surgery. You can have like respiratory symptoms like shortness of breath, tightness of the chest pains even. You can have cardiac things that seem like heart racing. It's probably anxiety related, but you can feel like your heart's racing or skipping beats. You can have all this kind of musculoskeletal arm pain, meaning muscle pains in the arms and legs, and joint pains. The GI tract, you can have constipation, you can have diarrhea, bloating, swelling, cramping. You have urinary symptoms like frequency, irritation, feeling like you have a UTI all the time, skin changes, eczema, rashes, total body acne. If you can just name some things, they will pop up as, quote unquote, symptoms. And these are just symptoms of chronic inflammation. And there's not a real rhyme or reason to why all of them are happening all the time, other than, like I said, like you've reached your capacity to handle it all. And your body is trying to, if you want to think of like express it and let you know there's something wrong. You don't know what it is. The providers don't know what it is because it doesn't make a lot of sense to them. And I've had patients with and without implants have the same symptoms. I think there's this confusion that I'm so like I'm more interested in what's going on with the patient. I think some people get caught up in the whole breast implant thing, but the curiosity is like, why is somebody's inflammation being driven
Hmm.
and what is the cause of it? Rather than, breast implant illness, as I think of it, is a chronic inflammatory process of which an implant's playing a role. It's not the only reason.
Hmm.
I've highlighted that, 29% have problems with, bacterial contamination. Others may have other problems with antibody production at the tissue levels, and some won't have any. They'll have some level of inflammation, but there's going to be all these other drivers that happen, until we work through the program. And that's really what the methodology is about, trying to identify those
Hmm.
genetics, toxicity issues, gut health issues, sensitivities, hormonal imbalances, and utilize those to, effectively identify the opportunities to prepare the patients and lower their inflammation. And if it's for their wellness, great, then they can just do that. If it's for preparation for a surgical procedure, like today I got called and somebody said, can I use your program before my cruciate, your ACL surgery? And I said, yes, of course. That's totally fine, because they just want to recover quicker. And we know all those pathways that are limited or that could be optimized. Like, you have genetics, but it's not because you have limitations genetically that you're indicted to a certain outcome. Like, there's ways to, if you will, work around it. Like, you can supplement, you can then curtail your exposures. Like, I don't metabolize gluten very well. I don't have celiac disease, but I shouldn't eat a lot of gluten. So that's a conscious decision that I make each and every day not to eat gluten. Is it going to kill me? No, but I'll exceed my enzymatic capacity to deal with gluten very quickly. So I just don't expose myself to more and more of it. I also am very sensitive to mold. So, like, I have an air filter right next to me. Austin has a lot of mycotoxins in the air. Overall, it's not just one thing. Typically, it's a whole combination of things.
So yeah, really understanding what's going on with the patient, and just like, oh, they've had this surgery, now they're getting this. It's like, where's that? What are making those factors of inflammation? Where's that coming from? Genetics to other things going on in their body. A real kind of person-centered approach, it sounds like.
Yeah, there's a lot of, we hear the concept of bioindividuality a lot. And I mean, it's more that. I mean, people kind of banter about precise medicine and what does that mean? And, understanding someone's genetics and trying to listen to their history and where they lived and worked and traveled to. Those are all important aspects of why they are who they are. Those are your exposures, your experiences through life. I think that makes sense.
Absolutely. I wanted to kind of ask you a slightly different question. Around, as a surgeon, you're performing lots of procedures, you're, dealing with like all sorts of different things going on in the body. Like, how do you personally deal with things like stress and the high mental load that you, you have to deal with day to day?
Yeah, I mean, that is always, I would like to say I do a good job with exercise. I think we could all probably do a bit better job with that. That helps a ton if you can do that. Minimum should be like 3 to 4 times a week if you can do it. Because my schedule is so busy and I'm in the operating room full time Tuesdays and Thursdays, it's hard on all those other days to just completely go off and do something, but that ends up being good. My wife is great about trying to get me out and go for a walk in nature. That's a great way to, help you always. So we encourage that for our patients. I try to get patients, and I try to do this as well because I'm up really early before the sun comes up, is once the sun comes up, go out and get some actual sunlight, and that helps your circadian rhythm. Many times, our lack of sleep or sleep hygiene is poor, and that leads to a lot of other problems, whether it's hormonal imbalance or our cortisol's off because of our circadian rhythms being off. So trying to get that normalized. And then, to be honest, the thing I prioritize the most is sleep. And the way I do it is I'm pretty disciplined about what I'm doing. So about 3 hours before bed, I have my last meal. About 2 hours before bed is the last time I'll have fluid intake. And then an hour before bed, I'm like just winding it down, cooling off the room, trying to get everything organized. So when I actually go in and go to sleep, I can just get off to sleep and it's relatively easy. And then because I get up sometimes at 4:30, 5 in the morning, typically I'm good to go. Patients always ask me, have I had a good night's sleep? And I try to be very consistent about my sleep. So those are the things probably that I do on a day to day that make the biggest difference, for stress. And then when I can, I get into our hyperbaric chamber and our lymphatic massage. I think lymphatic massage is great for just overall health.
Amazing. I love the sleep reminder, a thing that's very neglected often, but big
Yeah,
difference.
100%.
No, Dr. Rob, no, thank you for everything you've shared and all like the insights and awarenesses I've certainly got from you today, and I know the listener has. I'd love to know where, I know you've got a few things, where is the best place for the listener to find you, find out about your work? If maybe they've got this challenge themselves or know someone and just want some more
Yeah.
information.
Yeah.
And yeah, is there anything else you'd like to leave us with today?
So there's two real ways that I feel like the listener can gather more information. We put together, I think, the most comprehensive website in the world around breast implant illness, diagnosis, symptomology, treatment, recovery, and breast implant associated cancers at drrobertwhitfield.com. So drrobertwhitfield.com. And then within that, we started a private community so people can interact with us. I live stream from it several times a week. So within that community, they can come in, they can ask questions. There's no censorship in that community. We moderate it. So it's unlike the other platforms, I will not mention them, that have a great time censoring me.
That's great to find you at that on your website and that platform for your private community as well. So yeah, we will link those in the show notes below. So to get more from Dr. Rob, just click in the show notes below and you can get access to him via those links. So Dr. Rob, I just want to say a massive thank you for everything you're doing and for coming on today and sharing so much with us.
Yeah, thanks for having me on. I really appreciate it.
Of course. So that concludes our episode for today. And remember to lead with your heart and not with fear.